Hello and welcome to By the Book, a podcast series from ASCO that features compelling perspectives from authors and editors of the ASCO Educational Book. I'm Dr. Pedro Barata. I'm a medical oncologist and a clinical trialist at University Hospital Seidman Cancer Center and associate professor of medicine at Case Western Reserve University out of Cleveland, Ohio. I'm happy to serve as a deputy editor for the ASCO Educational Book. Today, we'll be talking a little bit more about exercise. We have plenty of evidence that exercise benefits symptoms, improves quality of life of patients, and actually is being shown to reduce risk of recurrence of cancer, but also improving survival. And I think that's increasingly clear as data emerges. Today, I'm delighted to be speaking to Dr. Kathryn Schmitz. She's a leading expert on integrating exercise into cancer care. Dr. Schmitz serves as the deputy director of the University of Pittsburgh Hillman Cancer Center and also professor of hematology oncology at University of Pittsburgh Medical School. She's a senior author of a fantastic article in the ASCO Educational Book that's titled Implementation Science as the Secret Sauce for Integrating Exercise Screening and Triage Pathways in Oncology. She also led a really compelling piece, just got published in the JCO, titled, If Exercise Were a Pill, We'd All Prescribe It to Patients with Cancer. But it's not. So I'm thrilled to have Dr. Schmitz joining us today and helping us explore evidence-based exercise oncology programs, how to incorporate exercise into cancer care, and also how to connect the right patient to the right program. So with that, welcome, Dr. Schmitz. Thank you so much for taking the time to chatting with us.
Thank you for the opportunity.
One of the highlights of ASCO last year and practice-changing, in my opinion, data out of the New England is called the Challenge trial. It did provide high-level evidence that a structured, supervised exercise program could improve both disease-free survival and overall survival. This is a study in the GI world, but I think it got a lot of attraction and attention beyond GI world across solid tumors, really. Could you give us a little brief recap of that trial and what have you seen as being the impact in practices around oncology?
So Challenge was very exciting. Prior to Challenge, there were any number of observational studies that indicated that there was a relationship between being more physically active and reduced recurrence and improved overall survival for colon cancer in particular. Notably in 2006, Jeff Meyerhart published 2 papers in the same same issue of JCO showing very, very similar data from 2 very large studies. And those were studies number 5 and 6 in this area. There's a lot of evidence observationally, but we don't generally change clinical practice on the basis of observational data. So we were all waiting very impatiently for the results of the Challenge trial. And it was very exciting to be in the front row when the results were reported out and to be part of the group with a standing ovation for the authors when it was presented. To summarize, 889 colon cancer patients, stage 2 and 3, were randomized into either a structured exercise program or a health education control comparison group and followed for an average of 7.9 years. And the structured exercise group had a 27% reduced risk of recurrence and a 38% improvement in overall survival. One of the things that's really notable about this is that what we typically expect is that when we go from the observational literature to the clinical trial literature, that we expect effects to go down. We expect to see a larger effect in the observational than in the RCT land. And that did not happen here. We actually see an effect that matches what we've seen in observational literature, which is really, really exciting. And one of the reasons why this has been so exciting across not just GI, but other cancers is the notable finding of a reduced risk of second primaries. So they only observed 2 breast cancer second primaries in the treatment group and 12 in the comparison group. And overall, they reduced the second primaries occurrence hazard ratio was 0.5, 50% reduction of second primaries, which is just remarkable. It really got everybody very, very excited. And now the big question, of course, is, all right, how do I do this? How do I make this happen? The thing to note is that what they did in Challenge is probably not doable in your clinic tomorrow. It's a heavy intervention. The number of touch points from staff is extensive, and the amount of time needed from staff for the coaching and supervised exercise is extensive as well. The criteria for getting people into the program required that people go through a series of blood tests and imaging tests that would just simply not be possible for the average community oncologist. So I'm guessing that you're going to ask me some questions about how we do this.
Right. That's a fantastic segue. That's exactly right. Walk us through, maybe starting by what does that mean?
The first thing to say is I have to go back to the observational literature, and the observational literature shows really compellingly that we have a strong reduction of breast cancer recurrence and mortality from being more physically active, prostate cancer recurrence and mortality, and colon cancer recurrence and mortality. I find it very difficult to believe in this day and age, in our current environment, if you will, that we are ever going to have the equivalent of challenge for prostate or for breast cancer. There is an ongoing study in prostate that's led by some Australian researchers, but I just don't think that it's likely that we're going to mount something similar for another tumor site. We have tremendous correlative data that indicates that there are a number of biomarkers and biological pathways through which breast, colon, and prostate cancer would be reduced in recurrence if people are more physically active. And so there is really, from my thinking, very little to state that it would be just a colon cancer effect. And so this is something we probably can enact in more than just the colon cancer community overall, which is great news. And it makes it easier for us to be able to enact this type of programming.
One of the things that comes up perhaps often is, if I were the leader of the cancer center and were to incentivize the different care teams to implement an exercise program at each level, GI team, GU, breast, thoracic, etc., how do we do that?
So I want to give you an analogy. You're a medical oncologist and you prescribe your patients chemotherapy. Now, just imagine, if you will, what would happen and how likely it would be for your patients to get chemotherapy if there was no chemo infusion suite. If the chemo infusion suite disappeared tomorrow and you were to tell your patients, go get some chemotherapy, what proportion of those patients do you think would go find all of the equipment necessary and all of the drugs necessary and understand how to dose the chemotherapy for themselves and get that all done? Very few people would do it. So with exercise, why would we be surprised then that our patients don't actually do a whole lot if we just simply tell them to go get some exercise? Exercise is a medicine. It is effective like a medicine. We've shown this through the challenge trial and many other correlative studies, and an ocean of observational data as well. So the question is, how do we build the infrastructure that is necessary in order for your patients to do this? So the very first thing that has to happen is that somebody has to tell the patient to exercise. We currently do not have a culture of exercise in oncology. We do in heart disease. If you ask the average person on the street, is exercise good for your heart? Anybody with an 8th grade education is going to say, yes, of course, because the American Heart Association has done an amazing job telling everybody that exercise is good for your heart. But what has ASCO done, frankly? Can I be that bold? What has ASCO done to tell patients that they should be exercising during and after their cancer treatment? I'm not sure that I know more than a guideline. There is a guideline, and that's great. The guideline is very helpful, but I'm not sure that patients know that there's a guideline. In fact, I can tell you that patients don't know that there is a guideline. So, making sure that there is a paradigm shift in the country that says exercise is good for patients during and after their cancer treatment is the first step. And the second step is getting a medical professional to say something to the patient about the exercise. And I'm very careful with the 2 words that I just chose: medical professional. I do understand medical oncologists are very busy. I understand that there's a whole lot to say in that 15 minutes when you're with the patient. And so maybe it isn't the medical oncologist. Ideally, it would be, but I get it that there's limited time. So it could be a nurse practitioner, it could be a nurse, there could be a social worker, it could be somebody else on the team that says, hey, we want you to do an exercise program. We want to connect you to an exercise program. And then there's, what is the program itself? I'm very interested in this happening across the entire country. And so I've been working with the leadership of the Commission on Cancer on the question of, well, how would you do this in community oncology? It's not enough to do it in academic medicine. How do you do this in community oncology? And, you can't expect that every community hospital is going to build a gym for their cancer patients. That is just not reasonable to do. So we start to try to figure out some phone counseling. Could we give people Fitbits and follow them? Could we use technology to help us? Are there telehealth opportunities for us to do? Are there apps that have been built? In fact, there is an app called Cancer Exercise. It's on, all of the platforms and available to patients. So there are programs. I've developed a directory of over 2,000 programs that exist across the country for exercise oncology that patients can find, medical oncologists can find. So there are a lot of people trying to figure out how best to get the information to medical oncologists and other medical professionals so that they can have an easy button to be able to connect their patients to existing programming so that you don't feel like you have to build a whole new program.
If I don't have the resources around me, what would be your advice for the care team or for the providers that might not have that available at their site? Where do they start? Who do they reach out to? Who should they be looking at to get more information how to set it up?
I lead an international consortium called Moving Through Cancer. You can find us at movingthroughcancer.org. That's where you'll find the map of all of the programs across the country in the directory. We actually have a triage tool that sits at the front of the directory that allows people to discern what type of exercise they're safe to do. We do recognize that, the 80-year-old that fell last week doesn't need the same program as the 35-year-old that was playing pickleball the day before diagnosis. So, there are different kinds of programs for people at different levels of acuity. We're happy to be helpful to folks to help them set up programs. But the number one thing is to really be very aware of the power of saying something about doing exercise, just simply the power of saying, I want you to be moving. Because frankly, I don't think anybody listening to this would disagree. No one benefits from sitting on the couch all day. No one, no one, no one. It doesn't matter how acute their medical issues are. We get people out of bed. We try to move people even when they're in the hospital. So I think saying something is huge. And then if you can, applying a triage tool, if you can get something embedded within your clinical flow so that you can understand who it is that needs to go to physical therapy as opposed to who's ready for an exercise program. Those are the two things. So triage and referral is kind of step one. And if you can get that done, the rest will fall into place.
This is really powerful message. Where one, awareness of the care teams. Number two, bringing it up to the patient. And then working on the referral, triage and referral process. That's fantastic. Another aspect that comes up quite a bit is like, look, this is great, but we have a system that relies on payers to make things happen, or at least to get them approved. And that can be very different or heterogeneous. The coverage can be different. Sometimes already going through a system programs for interventions, therapeutic interventions, let alone probably the insurance is not going to cover that. Is that true? Is that not true? How do you walk through the different insurance supports, perhaps, depending on where you're practicing?
You've just hit on the hot button. I've been working on this issue for about 9 years now, trying to figure out using efforts to talk to CMS and see if we can get third-party payer coverage going. We were making good progress there, and there was a change of administration and a new focus on Make America Healthy Again, the MAHA movement. And, CMS is really no longer interested in one-off national coverage determinations. They want to know, how do we make exercise happen for every American over 65? And my question is, well, wait a minute. Cancer patients are not just older patients. There's a lot going on there. They need something special. So been working on that, been working with accrediting bodies for policy with a little p. Very proud of the work that I've done in collaboration with the National Accreditation Program for Breast Centers, trying to get standards to get exercise referrals for breast patients, and currently holding my breath to see whether the COC is going to try to make some forward motion in this area as well, crossing all paired appendages, waiting for news there. So it's not paid for unless it's done by a physical therapist. And, there's published evidence, and I have plenty of evidence from UPMC as well, that people don't really want to go to the physical therapist for this. I'm not saying physical therapists aren't great. Physical therapists are great. And there are people who really need to go to physical therapy. And we try hard to get those patients connected. But for the patients that are ready for something more than physical therapy, we really have an uphill battle to try to figure out what insurers are willing to pay for and what the return on investment is. One of the challenges with the return on investment is that the time course for return on investment for American insurers is about 1 year. And I'll remind you that the time course for return on investment for challenge was 7.9 years. So we have a mismatch there. So we're trying to figure out if we can produce the evidence to show that there is an improvement in unplanned healthcare utilization. We have documented that for breast cancer. We're working on it for other cancers. If we can document that it is worthwhile to the insurers to pay for these programs, then I believe that they will pay for them. My conversations are very positive with UPMC, which is a very large insurer and large health plan. We're slowly working our way towards the middle where there's a program that they can pay for and a program that is efficacious. That's the puzzle we're trying to solve for right now.
This has been a wonderful and super helpful. Before we wrap it up, is there anything else you'd like to share with our listeners?
I want to make sure that your audience is aware that there are a variety of ways that exercise oncology is practiced. The program that most oncologists will be familiar with is Livestrong, which is a program at the YMCA. It's a free program. At one point, there were over 800 locations across the US. They have contracted since COVID, probably because of COVID. So they still do exist. But imagine, if you will, telling your patients that chemo is only available Tuesdays and Thursdays at 7 p.m. It would be difficult for patients to get there and get the chemotherapy. The same thing is true for the Livestrong program. It's a fantastic, fantastic program for people who are able to get there. But that's one option. Another option for patients is there are a variety of online opportunities. I'll call out 2 Unstoppable for women's cancers. It's literally the number 2unstoppable.org. It's a free program available to women with cancer to have live small group training programs. And they're based in Virginia, but they have programs all over the country. And then finally, I just want to overemphasize the app, the Cancer Exercise app. It's literally called Cancer Exercise in the App Store. And that is a super duper easy button, very comprehensive, developed by a nurse scientist, Anna Schwartz. And then there are a variety of books. I wrote a book called Moving Through Cancer. There's a new book out by Rob Newton as well. He's an Australian author. And there are certifications for exercise professionals that folks can look into as well through the American College of Sports Medicine.
Dr. Schmitz, this is fantastic. Thank you for sharing those great insights with us. Super, super helpful. Thank you for taking the time.
Thank you so much.
Thank you to our listeners for your time today. Remember, you'll find links to Dr. Schmitz's fantastic educational book, as well as the JCO article in the transcript of this episode. I'll invite all of you to go and read. And we'll also include a link to Dr. Schmitz's book titled Moving Through Cancer, an exercise and strength program for the fight of your life, which empowers patients and caregivers in simple 5 steps. So with that, please join us again next month on Buy the Book for more insights on key advances and innovations that are shaping modern oncology. Thank you very much for your attention.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.